Hello and welcome. My name is Kerry James. I'm the Chief Executive of the World Hepatitis Alliance, which is a network of patient-led organizations in almost 100 countries around the world. And today, the topic for our webinar is COVID-19 and the effect that it's had on harm reduction services and people who use drugs. And really looking at, as we move through the pandemic and eventually out the other side, how can these services be evolved and adapted to better serve those communities? So we have a great selection of speakers and of panelists from all around the world today. I should just let you know that this isn't a live session. This is pre-recorded, but please do feel free to leave comments and we will come back and answer them the best that we can afterwards. So I'd just like to introduce our first speaker, who is Niklas Luhmann, from the Global HIV, Hepatitis, and STI Department at the World Health Organization in Geneva. And he's going to give us an overview of COVID-19 harm reduction services and people that use drugs from a global policy level. So over to you, Niklas.
Dear colleagues around the world, I am very happy to join this important webinar that's organized around World Hepatitis Day that we celebrate every year. And I will present today on viral hepatitis, harm reduction, and the COVID pandemic. I'm Niklas Luhmann. I work as a technical officer in the Global Hepatitis program in the WHO in Geneva. And I welcome you all for this great webinar. I will have a talk that is divided in two parts. The first part, I still wanted to highlight before we talk about COVID, the role of harm reduction services in hepatitis elimination. I think this is a really important point because, as many of you will know, historically, the harm reduction response has been designed and supported mainly from the HIV field. But as we can see here in the data that I'm showing, and as you will be aware of, there's as well a very important interlinkage between viral hepatitis and injecting drug use. So it is really important to look at harm reduction as well, in addition to the HIV perspective from a viral hepatitis perspective, to make the biggest change in public health that we can do together. As you can see on the slide, we estimate that globally more than 11 million people are currently injecting drugs. It's estimated as well that almost 40% of those people have chronic hepatitis C infections. The overlap with HIV infection is as well quite important, and almost half of the people around the world that live with HIV and hepatitis C co-infection are actually people who inject drugs. It's particularly important to note that unsafe injection drug use contributes a considerable amount of new infections to the global hepatitis C epidemic. There are two estimates, one is 23 and 39%. So in between those, we estimate that this is the contribution from unsafe injection drug use to new hepatitis C infections. And then it is estimated that 1 in 3 deaths from hepatitis C are attributable to lifetime injection drug use. So all this shows this important interlinkage between viral hepatitis and notably hepatitis C and injecting drug use, and the importance to address injecting drug use as well from a hepatitis perspective. I wanted to show as well this slide, in addition to the epidemiological numbers. It's a standard slide about what are the core ingredients for national action plans, in this case, national action plans for viral hepatitis. And as you will see on the slide, this is a combination of essential services, health information systems, the costs, and as well the population coverage and equity. So I wanted to show that slide to really enforce and reinforce that point that equity and serving the vulnerable populations is part in general of a good public health response and of a good viral hepatitis response. WHO has set targets and has written a global health sector strategy for viral hepatitis that was voted in 2016 by the World Health Assembly and its member states. This strategy shows what would be the impact targets to eliminate viral hepatitis as a major public health threat by 2030. And you can see in orange the reduction of new infections for hepatitis B and C of 90% as the major incidence impact target, and a reduction of 65% for mortality between 2015 and 2030. Those are the targets that have been set in this strategy. And to reach those targets, the strategy has set as well 5 areas of core interventions, of which 4 are prevention interventions shown here on that slide. And one of those prevention interventions is harm reduction, in the strategy actually defined as syringe and needle programming. But I would like to say that it is really the combination of needle and syringe programming with opioid substitution therapy that we think would make the biggest difference to viral hepatitis prevention. The strategy refers to needle and syringe programming particularly because it didn't want to set 2 targets in this particular area. So in these 4 prevention interventions, you see in gray the gap to the 2030 targets for those interventions. And there are 2 which have an important gap. It is hepatitis B, timely birth dose, and harm reduction, where the gap is the biggest in the prevention interventions. And you will possibly know that only very few countries around the globe, including the high-income countries, have sufficient coverage of harm reduction interventions for NSP and OST. There is as well another important gap, which is the access to testing and treatment here for hepatitis C, but the cascade for hepatitis B looks very similar. So on the left side, it is the estimated number of people that are infected by WHO region. And then you see the number of diagnosed, that there is a major gap here as well in gray, and even less people are on treatment or cured in 2017. I wanted to show that because for people who inject drugs and people who use drugs, harm reduction is the major prevention intervention, but it is as well the important platform to allow access to testing and treatment. And this combination really makes a big difference in people's individual health and on a public health level. So in treatment access, we have seen some champion countries to really take the way forward and make major progress, but on a global level, as you can see, the cascade data still shows major gaps. Unfortunately, we do not have much disaggregated data, meaning we don't know among those who are accessing testing and treatment, how many are those from vulnerable populations, for example, people who inject drugs. So this was really to show the importance of harm reduction access for the viral hepatitis elimination agenda, and as well the importance of testing and treatment access. So now just wanted to highlight in a second part as well some information that we at WHO have around the COVID pandemic and people who inject drugs and the harm reduction service continuity. So as you know, we are now many months into what one could call certainly an unprecedented epidemic that has changed our healthcare systems and our lives quite considerably in the last weeks and months. So here I just wanted to focus on the fact that vulnerable populations, such as people who inject drugs and people who use drugs, may be of increased risk for infection from SARS-CoV-2 because they might have a more difficult time to apply the measures of social distancing or confinement, because some of them might be living in precarious housing conditions or even be homeless or other reasons to make it more difficult to follow those rules, and some may take increased or potentially increased risks through risky sexual behavior or risky drug consumption behavior, including sharing smoking material or others that might increase the risk for SARS-CoV-2 transmission. In addition to that, vulnerable people and people who inject drugs may have an increased risk of really developing severe COVID-19 disease because of additional comorbidities such as HIV, advanced liver disease, or TB, for example. And there's generally often in these populations a limited access to health services. So overall, we see an increased risk for infection and severe disease potentially. So what has WHO recommended really around this question? And I think it is important that we have developed two core documents, one focusing more on community services and prevention and the other more on clinical care, that you can see on the right side of this slide. And they recommend that it is critical that services that reach people who inject drugs can continue to provide life-saving prevention and clinical services. And this is important because those documents really look into what are the essential services that should be continued and or prioritized when a country is developing its COVID-19 response. And I think we know all that all countries have seen some disruptions or delays in healthcare in general. And so this obviously concerns as well the topic of opiate substitution therapy, community-based harm reduction. More generally, the documents, especially the prevention one here, recommends that people are informed about the changes in practice, that some of the services might move to the community, but to as well potentially maintain facility-based services if that is helpful and for the most vulnerable. It recommends as well to look into supplying bigger quantities of commodities and to change the delivery to sometimes innovative community distribution mechanisms or through pharmacies or others. And this can include condoms or clean syringes and needles, for example. More specifically, in terms of OST, I think we've seen quite interesting developments. We've heard, for example, from India, Myanmar, and Nepal, that really those countries, as an example, have moved quite quickly to initiating different take-home dose policies for methadone and buprenorphine in the framework of their OST programs. Often those have been lower scale or have not been really consistently existing. So this is a very pragmatic response, and WHO has always recommended to consider take-home OST. So this is a shift that we're seeing, and it would be possibly important and interesting to evaluate how the outcomes of those programs are, and if in the future some of those practices can become standard and can be continued. So some of those countries have as well adapted their psychosocial support within that and maintained facility-based services here as well. In terms of changing the drug supply for HIV and hepatitis B and hepatitis C, you can see as well some potential recommendations on the slide here. And one other country that has really seen those OST take-home dose developments is Morocco, and you can see here that they have changed to take-home dosing for stable patients that or for patients that have been stable over 2 weeks. Patients had to sign a contract. There were psychosocial and support virtually, and this has been possible really mainly through collaboration from MOH and clinics and communities and the police, and has initially had quite good results. So that is another example for a country that has really chosen a pragmatic and new approach here for this life-saving and very important intervention. So here you can find some of the guidance that I've mentioned and one or two other ones on this slide if you want to read in more detail about those. And I really thank you again for having me on this webinar, and I am looking forward for the discussion. Thank you very much.
Thank you, Niklas. And now we'll hear from Rachel Halford, who is the Chief Exec of the Hepatitis C Trust in the United Kingdom, and she's also the Regional Board Member for Europe of the World Hepatitis Alliance. Rachel, over to you.
Thank you, Carrie. It's great to be here. My name's Rachel Halford. As Carrie said, I'm the CEO of the Hepatitis C Trust. And today I'm just going to give you a whistle-stop tour of the Hepatitis C Trust. We're a charity, we're a patient organisation. We have 60 paid peer support leads and 80 volunteers working with us. I'm going to give you a little overview of the activities that we managed to complete during the COVID lockdown, and then I'm going to talk a bit about harm reduction and moving forward. So first and foremost, I just wanted to say that when the English government announced national lockdown at the end of March, we'd spent the last year tripling our workforce and embedding peer support leads across the country. In comparison, it took us a really short amount of time to shut down. But it's really important to acknowledge that the amount of work that we had to put into place to allow us to continue with our activities. And much of that, was about creating policies, protecting our staff, risk assessments, operational policies, and also personal protection equipment, PPE, looking after our staff and keeping them occupied for those that couldn't go out. So in the UK, the majority of the screening is completed in drug services, and lockdown meant that testing was not a priority service. With few exceptions, such as prisons still screening on entry, screening came to a halt. Next slide, please. Thank you. So in terms of linkage to care, for those who are already on treatment, this continued. We supported hospitals and pharmacies by delivering medications to patients. Other hospitals use home delivery care. So in this slide here, I've just tried to highlight some of the areas where we work, some of the work that we've been doing. So on our books, when we went into lockdown, we had over 2,000 patients. So much of our concern and our emphasis has been on supporting those patients alongside supporting our peers. So there's been an awful lot of telephone contact. Where peers and patients haven't had telephones, we've sourced telephones to make sure that they can stay in contact. We've supported clinicians and nurses by delivering medication. We've maintained our helpline, and we've also extended our prison helpline to 7 days a week, 12 hours a day. Part of the work that our peer support leads have done in the community is they've gone to pharmacies, they've picked up medication. A lot of the people that were on treatment, rather than them go back into the environments, kind of dangerous environments, particularly if they've got more severe liver diseases, we actually arranged to pick the medication up for them from the pharmacy and drop it back to them. We also supported people by buying food packages. A lot of the people that we work with are from the lower socioeconomic scale and essentially have very little resources. So we would go out and we would buy food packages just to make sure that they had enough of the basic needs. Additional to that, we looked after our peers who, are volunteers. So we have an awful lot of volunteers. Like I said, we have about 80 volunteers. And what we did was we ensured that they all had mobile phones that could access internet. And we provided online training, online connection. We had check-in groups, we had meditation. For a lot of our peers and our volunteers, the work that they do with us is their main contact outside of their day-to-day lives, which can be really isolating. So it was really important to include them within our training programs and our day-to-day activities. So as I said earlier, in terms of linkage to care, we supported the hospitals and the pharmacies by delivering the medication. For those that were diagnosed, by and large, everything was really put on hold during COVID. But I have to say that there were a few exceptions, and that's what has been quite remarkable about this lockdown period. You know, there was an example in the north of England where one of the hospitals actually went through their whole list of people within the prisons, one of their prisons in the north, and with the use of telemedicines, they actually managed to treat every single person during this lockdown period, which is quite interesting in itself because telemedicine's been around for a really long time. And actually, I think, you know, and hopefully across many countries will have seen this, it really came into its own during this period. Next slide, please. One of the other things that we did, which was really important, when we first locked down, we found that there was a lack of information for peers, for general public, but also really a huge lack of information for people who were using drugs. So harm reduction information tied into COVID with some key safety tips. So we created these seven safety tips, or 7 drug using tips. And this was really about coronavirus and some of the key things that you could look out for. For example, one of the things that came up for us when we did some research around it was you could be withdrawing, or not actually you could be withdrawing. Some of the symptoms of COVID are very similar to withdrawing. So it was really about getting the information out there for people who use drugs to know that you wouldn't necessarily be withdrawing. You could actually have COVID, and actually you should be perhaps taking action. This slide is just a real snapshot of some of the key interventions that we managed to do between this period of March and June before we started opening up again. So we completed 4,471 interventions. We supported 66 clinic visits, 195 people started treatment, and 519 were tested and found and offered support, so tested and found to be positive. Next slide, please. So partnership working during this time really took on another meaning. So across England, for the homeless populations, were taken off the streets and placed into hotels. This was not only offered to them as safety, but also provided us with the opportunity to address the many needs that they had, in particular health needs, and this included BBV testing, hepatitis C testing. Partnership team. So London is the best example that I can provide at the moment. But in saying that, this has happened across the whole of the UK now. In London, a team was very quickly formed, a partnership between hospital clinics, nurses, doctors, outreach vans, and the Hepatitis C Trust peers. And over the course of 6 weeks, we went out and we delivered testing and to whole hotels. We went to 46 venues. We tested 519 people and we found 41 positives. And of those 41, there were 11 that started treatment straight away. We also found, interesting, 6 HIV positives and 2 HBV antigens. What was incredible about this piece of work is that this is a group of people which we know are marginalised, we know have difficulty accessing health services. It was a unique opportunity, but it was an opportunity where we were able to engage them and address these issues. The testing events, as I said, have already spread, and they've spread across the country, and it's been a fantastic joint working effort. So moving forward, there's been much innovation across the country. People have had to be really creative. As I said earlier, the opportunities have been that, you know, telemedicine has been around for a long time, but it really came into its own during this time. And there's no, you know, I think that the opportunities that came from COVID, there's no doubt that, you know, there's more virtual clinics. I've spoken to clinicians as well, you know, and actually there'll be more, going back to face-to-face will be far less. For us as an organisation, there's been a lot of virtual training, and shared with other organisations. I think there's a wider remit for peers, not just with testing, but probably with dispensing of medications, etc. On the flip side of that, you know, I would be lying if I said there weren't concerns. There are huge concerns. you know, the core of our work is with drug services, and the core of the testing in the UK is done through drug services. You know, and during COVID, drug services shut down and actually just ran skeleton services for those very new presentations. And we did see a really significant increase in presentations. So, you know, there's a concern as we move forward that, you know, is there going to be testing provision, you know, as there should be? Due to the shutdowns and the reduction in needle exchange provision, will we see a spike in COVID? You know, I know from colleagues in America, there's an anticipation of a huge spike, particularly in New York, where there was no access to harm minimization, harm reduction services. So people were back out on the streets using street drugs and sharing needles. And I think that as we move forward, you know, it's important to say, you know, it's been an incredibly difficult time for people who use drugs and those that support them. We've seen an increase in the numbers of people accessing harm reduction services for substitution support. So finally, you know, I think just it's really important, you know, that the topic of this webinar is harm reduction, you know, and what we know is, you know, hepatitis C is a preventable disease, and yet the number of people acquiring new infections in the UK, and I can only talk for the UK at the moment, it's not falling. There have been dramatic improvements in accessing effective treatments. However, even with an elimination deal in place, elimination in the UK cannot be achieved without simply increasing the number of patients who receive treatment. Evidence suggests that treatment as prevention can work, but only if sufficient needle and syringe programs and access to opioid substitution therapy is available. You know, and we heard earlier from Niklas, you know, the WHO Global Health Sector Strategy was set out, you know, with one of the targets being a call for a reduction in new cases of hepatitis C. And what we know is that most new cases, new infections in the UK are acquired via injecting drug use, and therefore a comprehensive and effective range of interventions to prevent Hep C infections amongst drug users is required. This is really important moving forward. So sharing of injecting equipment remains common in the UK, and levels have remained unchanged for many years. Good needle exchange provision and consistent education around injecting safety is vital to achieving and maintaining the UK's hepatitis C elimination goal. So as a leading actor in efforts to eliminate hepatitis in the UK, the Hepatitis C Trust, we have pulled together, you know, we have some really robust aims to ensure that preventable infections are avoided. You know, and our key focuses and our key aims as we move forward, and this is really poignant as we move out of the COVID lockdowns, that, you know, that there is optimal and equitable needle exchange provision for all, you know, and that within that, robust data recording and analysis of the needle exchange provision is used and collected. We want consistent and accessible education and information around safer injecting and BBVs. And this includes for people who start using, who have not yet engaged with drug services. How can we get this information out to them? These people really are at an increased risk as they're more likely to be exposed to BBVs through injecting. And then finally, high quality, effective, accessible and meaningful OST alongside the needle syringe programs. This has to be easily accessible at the point of need and for as long as the person needs. And just finally to say, you know, we've seen some incredible initiatives, as Niklas highlighted, you know, as in Morocco there, you know, one of the things that's come out, I think, for the drug services across the UK is because people had to be given longer prescriptions, they've managed it really well. You know, people who use drugs really have come into their own. They've been able to show that actually perhaps they don't need the amount of monitoring that's been put in place previously. And that maybe as we move forward, you know, we need to be working in a new world, a new normal, you know, and maybe this is actually part of the new normal. So I'm going to leave it there and hand it back to Carrie. Thank you very much for listening.
Thanks, Rachel. It's great to hear about all the inspirational work you guys have been doing during lockdown. And I'm sure a lot of the themes and a lot of the issues that you brought up will also be a big part of the discussion that we're going to have now. So now I'd like to widen the group and bring in two new panel members. And I'm going to let them introduce themselves, and maybe they can tell us a little bit about their organization and what's been going on where they are during the COVID crisis. So maybe first, Edo, would you like to go first, please?
Thank you. And I'm happy to involve in this Zoom meeting for the World Hepatitis Day on this year, 2020. I'm from Koalisi Satu, Indonesia. We are talking about harm reduction now. And I will speak mostly what happened in Indonesia, not in Asia maybe. In Indonesia, for harm reduction services, the correlation between harm reduction and what happened with the COVID pandemic recently, I think it's very affected, especially for people who use drug who still accessing harm reduction services. Most of the components of harm reduction still deliver in a good way. For example, for antiretroviral, what happened here, we are okay with antiretroviral. We are not facing stock out. And for treatment and rehabilitation, also three organizations in Indonesia, we were sending a letter to the Ministry of Health and Ministry of Social Welfare, who are responsible for rehabilitation for people who use drugs in Indonesia. And finally, they released the SOP for rehabilitation during this COVID pandemic. But few components of harm reduction are not going well. For example, for hepatitis C, especially, we are already the government national program to testing and treat 6,000 people this year was stopped maybe almost 7 or 8 months ago because of stock out of the medicine. And until now we don't have the medicine, and because yes, the procurement process is very long. For the OST, especially for methadone, it's the SOP from the government, from the Ministry of Health. The client can access their methadone at least once a week, but there is problems with buprenorphine, because in some province the buprenorphine were stocked out, so the black market, so the price of buprenorphine increased almost 600-700% in the black market. The biggest problem is about needle exchange program. So it's almost 6 months, 7 months also. We are now facing, there is no needles in this country. We cannot access needle exchange in harm reduction services. The important component, I think, in harm reduction services.
Brilliant, thanks, Edo. And next we have Nonso in Nigeria. Nonso, could you tell us a little bit about the situation there?
Yeah, Gary. Thanks to Edo, Rachel, Niklas for those wonderful presentations and their discussion. My name is Nonso Maduka. I'm a pharmacist, and I work with an organization called Bensther Development Foundation. We're basically a public health focused organization. However, with the COVID crisis, we found ourselves also dealing with the criminal justice sector. Well, with regards to what happened to Nigeria, it was a shocker. It was a shocker in the sense that we have been working hard to get harm reduction rolling out in Nigeria, developed the guideline for NSP, got the government for the first time to be fully involved. All this while we have been doing harm reduction, especially NSP from the back door. But between the last quarter of last year, early this year, where things were already getting set, the Minister of Health have approved the harm reduction. The guidelines have been developed. Pilot states have been choosing. There are training of trainers, training of the implementers. And then suddenly COVID came in. It came in such a way that it so much affected the Federal Ministry of Health as per regards to their staff strength, that the staff overseeing the harm reduction program were actually uprooted. They were actually hijacked from their office, and everything about this. For us from the civil society, when the lockdown started, we wanted to be part of it, at least to take advantage of that period, that cover from the ministry, to join the people going out, and then by that we can be able to cover our communities. We are people that use drugs. However, we were too strict that cannot work. So we had we had to change our tactics. We left working centrally, that is working from the federal ministry, and everybody had to see what they can do in their states. And so coming down to the state where I am, which is actually Enugu State, we began to think, how do we go about it? So fortunately for me, being a pharmacist, I didn't have so much to do with restriction, and also because of that, my organization could also move out. And so what we did was, first of all, to reach out to the community members. It was a hectic time for them. You know, many of them survive on day-to-day work, income. And so with the restriction, there was no more the opportunity to go out to work. Two, we had the issue of homelessness. Many of the truth about this issue of drug use is that where we have issue are the poor, marginalized drug users, not the people that can afford to check into a hotel room and do what they want to do. And so for these poor, marginalized drug users, the lockdown was hectic. It was bad. It was bad in the sense that the cost of normal daily items went high. Harm reduction services came practically to a halt. Now, that is the backdoor harm reduction that the CSOs were doing. And then the government interventions didn't have any plan for them. It didn't have any plan for them. Was still in the attempt to curtail crime, especially in my state, the governor had to raid a particular bank, which happens to be actually the biggest bank in the state. It was hard. That by the time we came to reach out, because after we've seen what was going on, we knew that the risks of HIV, the risks of hepatitis C is going to increase. And unfortunately, we came in partnership with West African Drug Policy Network. And by that, we mapped out some banks and reached out to them, supplying needles, supplying immunity-building drugs like vitamin C, vitamin D, and then other things they need. So that was one thing we really did. Then we had to turn our eyes to the prisons. So first, paid a visit to the person that was leading the COVID intervention for the state, then who was the permanent secretary, State Ministry of Health, and I raised the issue of prison, and raised the issue that there are actually people that don't deserve to be in prison. And we have a case where people don't even go to court. You see a person that was remanded for the first time from a magistrate court because they caught him with drugs, and for the next 1 year, he has not gone to court again. Next 2 years, he has not gone to court. So raised that issue with the permanent secretary, Ministry of Health. He told me that we have to go to the Ministry of Justice. So I had to start going to the Ministry of Justice. Unfortunately, the Commissioner of Justice in the state shut down the ministry. That they are not working, they are not seeing anybody. And so to get to him physically was not working. Okay, pick the calls. They were not interested in picking the call because as far as they were concerned, there is a lockdown. The ministries are meant to be shut down. You shouldn't be coming and talking about anything. However, we had to move our direction to the judiciary. So we started engaging with the chief judge of the state and began to make recommendations. Started writing that they are kind of group of people because actually the government gave their criteria for the people that were meant to be released from prison. Unfortunately, non-violent drug offenders or drug users that were in prison were not called in that list. So for us, we now started a new kind of advocacy talking about why they need to let these people go, especially the fact that these guys are just been held in the prison, that they don't go to court. And so at the end of the day, the state carried out the chief judge carried out what they call jail delivery. And during that jail delivery, about 72 people were released. And out of that 72 people, 12 were drug-related offenses. So they were released. So that's what we did. Another thing was also the lack of knowledge of COVID among the community members. They really didn't believe it. The day I met with them, they were like, oh no, this thing is fake. Because we as, when we watch the cable TV, you see the people that have COVID infection, you see them on their sick bed, you see the effects. But with us in Nigeria, at that early stages, they were not showing anybody anything. I understood why, because the stigma level in the country is so bad, is so high. For the community members, they felt this is a fake, using this thing to nothing is actually happening. So it was another issue getting to convince them. But the funny thing is that it wasn't just with the drug use users, the drug using community, but it's actually within the general populace. They were doubting the real existence of COVID-19. And so we have to develop an IEC material that we have to deal with COVID first and then deal with the drug use rate. Now, one thing that was common was the scarcity of drugs. The prices were going high, and we knew that these guys will be running a risk of adulteration. And so we began to address certain issues, again, like encouraging them, this is not a time for you to look for a new dealer. As much as possible, you're going to stay with your dealer because of the relationship he will build. He will value your life than giving you anything. We began to talk to them about how to minimize the impact of withdrawal, like teaching them, okay, in a day, take at least, this is about, don't take anything less than 3 liters of water. Trying to help them to, okay, you need to start exercising, trying to find ways to keep these guys busy, especially those guys that were homeless and yet they were further displaced from their bunk. So it was really a hectic time for the drug using community in Nigeria in general. And then for my state, it was bad. It was bad. Actually, that led to a program we had. It led to a program we had. We had to gather the security and the judiciary stakeholders to have a discussion on the drug issue within the state. And it was well attended. We had the chief judge, we had the speaker of the House of Representatives, we have all the law enforcement officers, they were them. And the issue, it became a heated argument because certain issues were raised, the issue about the reading of the bonds that is not working. One of the things that happened was that we had the community member in the meeting, and they were talking to him, they were asking him questions. Now, they were asking him, okay, since you started using drug, have you gone for treatment? He said, no, he has not been able to go for treatment. They said, but have you been arrested? He said, yeah, so why? He has been arrested, he has been sent to prison. Now, an interesting question was asked by the somebody from the legal aid council. So say, while you are in prison, were you able to access drugs? And the guy said yes. And right there was a representative of the state controller of prison. So it was quite a hectic period for them, but we have done our best to cushion the effect of COVID. Thank you.
That's terrific. Thank you so much. I mean, obviously, everyone's been facing some incredible challenges, but also through that, community organizations have been finding, new solutions, and there have been some things that we've been, wanting to get some action on for a long time, like the flexibility in the provision of OST, and maybe some decentralization of services that has actually kind of accelerated at this time. So, we heard the phrase "new normal" a couple of times throughout the session. So, what from what's been happening now in the crisis, as we evolve, hopefully through the crisis and to the other side, what do we want to keep from the kind of innovations that have been happening at this time? Do we want to keep and continue on and make that sort of the standard operating procedure in the future? So maybe Rachel, maybe just one thing from the COVID crisis that you think we will hopefully be able to carry on doing afterwards.
Just one. Oh.
Well, you could.
One's tricky because I think that the one of the huge ones for people who use drugs has been giving them more responsibility. So longer term prescriptions, etc. When we're talking about harm reduction, if we're talking about hepatitis C as well, I think a wider use of peers. Peers have proven that they can go into pharmacies because generally they wouldn't have been able to pick up for another patient. They can go out and they can test. The use of peers could be far more explored, and I would love to see that further used in the new, whatever it is, normal that we're going into.
Great, thank you. Edo, what's one thing that's happening now that you would hope that would become standard practice going forward?
The fast response when the COVID pandemic started. Lots of community organizations already started to think about the availability for medicine, especially for antiretroviral, and best practice for when we are facing difficulty. I think sometimes lots of best practice become good. So I hope we can maintain that kind of response for hepatitis in the future.
Brilliant. And Nonso, what's one thing that's happening in Nigeria now that you would like to continue as we move through the COVID crisis? So that's a positive thing.
Yeah, the release of drug users held in correctional services. I felt that these people doesn't need to be here, especially with this crisis, and when releasing them was one thing. And if we are going to extend it nationwide, I actually saw that COVID gave us a platform for advocacy, serious advocacy on the legal status of drug use. So with that was one new thing that happened, and I'm so glad about it. I wish that it will continue.
Thanks. And Niklas, looking from like a global perspective, what do you think that we can take out of this crisis and move forward in a positive way?
Thanks, Kerry. I mean, I think unlike the others on the panel, I'm not working on implementation, so I think their thoughts are really very, very helpful, and I would echo the importance of peers, for example, that has been showed before COVID in many different services and organizations. But if that is something that becomes even stronger, that is possibly something really interesting to look at. The other thing I've already talked about in my short presentation is really that we have seen many countries moving on the OST delivery, and this is really something that is important for the life quality of people, for example, that access those services. and for many years. And so to come every day is really something that has a very heavy burden on your practical life. And it is maybe for some people as well a reason to reconsider OST if there's not more autonomy and flexibility. So I think that has always been something that should be considered, or was recommended to be considered by countries, but not many countries have done that on a large scale, at least in low and middle income countries. So this is really an area where I would think if that can be continued for those patients where it's adapted, that would be something that really changes and may allow as well over time to include more people, have less visits, less waiting time, less burden on healthcare workers, less burden on the general system, and more autonomy and flexibility for people who are users of those services. Thanks.
Brilliant, thank you. Well, I'm afraid that's all the time that we have for today. It's been a really rich discussion today, and I think we've had such great perspectives from the community from around the world and from WHO on the global level. And it's a terrible crisis that we're in, but hopefully we'll be able to move through it in a positive way to better serve people who use drugs in the future. So I'd just like to thank all our panelists for their insight and really giving us, an in-depth view of the situation in so many different parts of the world. And thank you, all of you, for tuning in. To find out more about other webinars available from the World Hepatitis Alliance, visit worldhepatitisalliance.org. Thank you, and see you next time.